I can relate the fact that the needs my grandmother has, right?
Yes.
Versus what say my mother has. Very different based on just where they're located,
Absolutely.
right? And the fact that you do mention that most of communities that in rural areas, here we might take it for granted. You have 1,000, but that 1,000 might be what they have for the month if they're lucky, because then they're relying on, agricultural produce from their farm. They're not necessarily commuting to work and all that, right? So there's also the element of beyond healthcare needs, financial in terms of just the muscle they have is different. And so when you're coming to talk about policy issues, you probably are not discussing at the same point. When you're talking about allocation, it's not the same issues,
It's
right?
very different. I'm already feeling the vibe. All right.
Hello, welcome to the One Health Lens podcast, where we have healthy conversations about global health, public health, and the road to universal health coverage. I'm your host, Dr. Diana Wangari Gitao.
And I am Dr. Simon Moshara Kegondu.
Today, I'll start by appreciating Doc here, Mr. Experience himself, right? Because in our last or one of our previous episodes around maternal child health, where we talked about postpartum hemorrhage, the introduction of heat stable carbetocin. And we've had a lot of feedback around this particular episode. And really, it was around a comment that Doc mentioned, which was feedback he got from the governor of Makueni, where he said, yes, I know there's the technical, medical speak, right? But more importantly, the people who are benefiting or people who are appreciating this new drug is the cleaners. And what the governor said was actually that they're calling it kaosha. And really, for you to understand what that means, is that cleaners are saying they no longer have to mop blood from bleeding women, right? That the impact is such that cleaners themselves are saying this is a game changer. Thank you, Doc. And thanks to the team as well. But today, as always, we have important guests in the studio with us. We have another important guest. And we're here to talk about the role of health facilities, yes, in universal health coverage, but also the current situation in Kenya, right? We've seen this week hospitals really stopping to take NHIF, if that's the terminology I'll use. But essentially, if you walk into a hospital this week with your NHIF card, which is soon to be SHIF, you would have to pay cash, right? And this is the conversation we're having today with Brian Lishanga. Brian, you can introduce yourself.
Thank you, Dr. Diana. My name is Brian Lishanga. I'm a medical doctor. I do a couple of things.
Tell us, all of them.
So first of all, thank you for having me on the show, and thank you, my good friend, Dr. Kigondu.
Mr. Experience himself.
Mr. Experience. And I mean, I was just telling him that the first time we had an encounter, my take from him was, how can you be so experienced at such a young age? You know?
Little
so
do
the
you know.
perception was that. So that nickname is very apt, I think. And so I'm very happy to be here. My background is I did medical physiology back in 2009, finished 2012, around there. And then, so at that time I started teaching as well at School of Medicine at Egerton University.
Okay.
And I've been doing that for the last now 15 years. And then I also, studied family medicine as well. So both my feet in science and in primary care. So that is my medical sort of background. But I also do a lot of work in healthcare advocacy. So presently I am the chairperson for the Rural Private Hospital Association of Kenya, which is been in existence for 5 years now, this year. And we are basically a provider network that is privately owned and mostly operating in what you'd call underserved communities. So initially very focused on rural medicine, but as time has gone by, and also I think Kenyan demographics are changing. We are becoming a lot more urbanized, even in our home areas.
Yeah.
So we have quite a number of facilities that you'd call urban, but still serve the bottom of the pyramid, who are also increasingly becoming members of the association. So this is what I do between teaching and family. So it's teaching, family, and advocacy. So this is really my lifestyle.
Your lifestyle.
Yes.
Okay, great to have you.
Thank you.
You say rural. It's I know it's
RUPHA.
RUPHA.
Yes, it's
right.
RUPHA.
So 5 years in existence,
Yes,
right?
yes.
And going into that history, why did we have to have an organization, particularly for rural hospitals, right?
Okay.
Why?
So Kigondo warned me that this would be uncensored.
It is uncensored. So you're going to be politically correct.
I'm already feeling the vibe. All right.
Yeah.
So why? Question of why. So back in the day, sometime in 2018, around there. So personally, I've been in healthcare entrepreneurship for a while. My first venture into healthcare business was back in 2010, 2011, around there, which was a small outpatient. We came together with the colleagues. The team was 5 doctors. We had a dental surgeon. We have 2 guys. One of them is the guy who writes kitabu ya sukari, Dr. Katambo. Dr. Katambo was our partner. We had another, she was a young dental surgeon, then now she teaches for Moi University. We had an orthopedic surgeon called Dr. Lutomia. Dr. Lutomia now I think teaches at Aga Khan. And then I had Dr. Julius Okel, who is a nephrologist in Kisumu. So, but that's what they are now. But in 2010, 2011, they didn't have any of these titles.
They were hustlers.
Hustlers, I think they were hustlers. I think like the senior most was Lutomia, who at that time was just finished his COSEXA training in orthopedics. So we came together in Nakuru. And we're like, so we were all living in Nakuru. So let's set up something. So we did an outpatient there. So that journey led me down. So that's my first stab at it. Eventually, I ended up establishing a hospital in Njoro. So Njoro is about 22 kilometers. They say southwest of Nakuru town. As you are heading towards Elbagon, Molo, those areas. So Njoro is fairly agricultural, rural. It's like a small town, nothing much happening. You'll know everyone pretty soon. My motivation at that time was twofold. One, so since by then, this was 2015. By then I had been teaching for 6 years, but I had just finished my master's and I was feeling like I needed to get more settled, So I decided to move from Nakuru town to go and live in Egerton, staff houses.
Okay.
Because, the School of Medicine there is sort of like a split. The way here, University of Nairobi is, you have Chiroma and then you have KNH. So there we have Njoro and then we have Nakuru town. So Njoro is essentially the basic sciences, year 1 to 3, something like that.
Chiroma,
and then the 4, 5, 6, you find them in town. So since I was teaching physiology, I was basically teaching in Njoro the whole time. So I said, instead of this hassle of every morning I'm on the road to go to Njoro, so I'm essentially doing 50 kilometers about every day. I said, no. So I decided to move with my family to stay in the campus. And one of the things I discovered after living there for a couple of months, so I moved around mid of 2015. So by December 2015, it dawned on me that literally anyone seeking healthcare around Njoro, if they are looking for good quality healthcare, they still travel to Nakuru. Because now there was no private practice in Njoro town. Like you can't find a doctor. Now let me make this even more interesting. When I set up my facility, I was now the only doctor in Njoro.
Oh, really?
Doctor, I just say doctor, don't say even anything, just doctor.
A doctor.
Because Njoro Sub-County Hospital itself, which was my neighbor, didn't have a doctor.
In fact, I was going to ask you, there must be a sub-county hospital.
So there's no doctor. It was 900 meters from where I set up, and they didn't have a doctor.
higher.
So when I set up, I was actually the only doctor in Njoro.
So in the sub-county, you had what? Clinical officers, nurses?
Clinical officers, nurses, and maybe 2 or 3 clinical officers. You know, those staffing HR issues.
Yeah.
So now I experience rural medicine properly.
Yes.
You know, and so remember I told you previously I had set up in Nakuru town, which is, it's a city now.
Yes.
So here this is rural medicine, and it hit me that the dynamics are quite different. For instance, when I was when we were doing our thing in Nakuru, it was, you know, fairly common that when you're doing your books of accounts, say, you know, your management, there's a lot of cash that, you know, goes through.
Yeah.
But then when I set up in Njoro, despite all my optimism, I discovered cash is rare. You know, so, you know, people actually don't transact with cash for healthcare. And when they get pushed to the wall, they resort to wacha twende tuuze kakitu, ama let's call somebody. They call their sons in Nairobi, where, you know. So and then NHIF was starting to gain steam around 2015, 2016. So a lot of people were now picking up NHIF cards. So the few who had some form of health insurance, it was essentially NHIF.
Yes.
And nothing else. So you know, Njoro town has one bank. One bank, KCB. KCB has been there for a while, and I think it was there because of Egerton University.
Yes, that now makes sense.
But it's the only one, and it is skeleton staff. Equity have a presence, but Equity have an ATM. They have just like a place there with a guard. And so there is no, the point I was trying to make with that is that there are no people holding private medical cards, literally. You know. Then once you expand that into the economy of the area, you find most of the people are working for flower farms. So you know, you have this agroflora, bliss flowers. Flower farms are big around Njoro. They are massive. You know, they go all the way to Maunarok, where you start now getting into the wheat plantations and this. So a lot of people are farm workers. Now, we initially joined Kenya Association of Private Hospitals. This is where, obviously, that was the only association then that was available. And we had quite robust conversations in there. One of the things that, you know, created the divergence was the approach to the vision for health. So if you look globally, there is any serious country that has a healthcare system, providers have generally organized themselves in those two categories. So if you go to the US, you have the American Hospital Association, which is massive, but you also have the National Rural Health Hospital Association, Health Association, NRHA. And you have to ask yourself, why does that exist? And it's because even with our move towards urbanization, there's always going to be a community of people who will remain rural because of whatever reasons, you know, remoteness, whatever it is. Their healthcare needs, and I learned this when I was studying family medicine, that the healthcare needs of rural communities are distinctly different. So I felt at that time, with the team of guys we were with early then, that maybe there is need in Kenya. Kenya has come to the point where we need to have a small lobby or a sector lobby that, you know, keeps rural health on the table. You know, so that whatever happens to Kenya, no matter how we move, rural health should always be discussed. If you look at, for instance, COVID, one of the places, like now you go to the West, one of the places that were really hard hit was rural health, especially now in the Western world, because as they have advanced so much, they have reduced investments in rural health. And now they found out that they have no acute rooms in rural hospitals. They don't have emergency physicians to handle these things. The preparedness is extremely low. And who do you have in rural areas? Generally the elderly and retirees and people, you know, just, you know, they are winding down. And these guys were hard hit. Now, Kenya is going to get there at one point, and we're already there in some places. So basically what I think is it became obvious that while we are on the table discussing health policy, this voice cannot left behind. It has to be, given space and articulated. Granted, things have evolved, but we pride ourselves at RUPHA as being consistently able to speak for that constituency.
I like that. I mean, I can relate the fact that the needs my grandmother has, right?
Yes.
Versus what, say, my mother has. Very different based on just where they're located,
Absolutely.
right? And the fact that you do mention that most of communities that in rural areas, here we might take it for granted. You have 1,000, but that 1,000 might be what they have for the month if they're lucky, because then they're relying on, agricultural produce from their farm. They're not necessarily commuting to work and all that, right? So there's also the element of beyond healthcare needs, financial in terms of just the muscle they have is different. And so when you're coming to talk about policy issues, you probably are not discussing at the same point. When you're talking about allocation, it's not the same issues,
it's
right?
very different.
Yeah.
And let me just also add something I experienced. So I put a lot of investment into setting up that place. I ended up having a 30-bed hospital, and I had these wild imaginations of how it would be. You want to you want to do
change the world.
You want to change the world. You want to do state of the art things.
State of the art is
ambience. All this kind of stuff. And then I quickly ran into headwinds. For instance. Just getting somebody like Dr. Kigondu to come sort a hysterectomy for me was hell. And it's not really their fault. It's geography.
True.
So if a specialist is running a busy clinic in Nakuru town, and we don't have enough of them anyway, so they are gonna be stretched already by the workload within just Nakuru.
Yes.
And for Nakuru, you could count how many gynaes we have. You can't count them.
Yes.
And because in your circles, Nani is retired, Nani amebaki. There are few guys.
Yes.
This guy is running a busy clinic.
And
he's already double booked by all the privates in town there. And most of them, they're not going to be running around at 2 a.m. to drive from Nakuru to come to Njoro to just sort out that PPH that is happening somewhere in Njoro. So I ran into a lot of headwinds with this. Like even now, forget even specialists, anesthetist. Just clinical officer, anesthetist to come and put anesthesia for the MO to do a CS. You literally, tafadhali kuja, uko happy, nini. So sometimes I used to wake up, so I work during the day, and if an emergency happens usiku, I'm told that the only CO anesthetist can be found is maybe, let's say 15 kilometers, 20 kilometers away. I get into my car, I go pick them in their house, bring them, we do the procedure, they finish, take them back. Now, now look at it. Even the wear and tear on my vehicle, the fuel costs. How do I bill for these things?
You can't.
I cannot bill them. And then also the other thing that became very clear is the reimbursement system that was developing around NHIF was disenfranchising rural providers. So things have changed quite a lot now, and this is one of the things I'm proud about, us working with guys like Kigondi and others. One of the things we have been able to do is change some of this. So for instance, they used to have contracts which were contract A, B, C, this is NHIF. And these contracts were developed because of the environment in which NHIF came to be. They were trying to do things the right way, but they didn't think through everything. So what happened is, like in Nakuru, all the larger hospitals in town took up what we call contract C. Contract C, what you call co-payment contracts.
Okay.
So NHIF would say, for instance, for an appendectomy, as guys, we are going to approve, say, 60K. But your hospital is free to bill the patient
whatever they want.
Yeah. So now it's a patient choice issue. So what happened was this. In essence, doctors, and I'm speaking because I'm a doctor, we are rational. Just I want you to figure this out. So this is hospital X. You're called to do an appendectomy. The total bill for the patient is going to come to 150. Say NHIF will pay 60K.
Okay.
The patient, either by cash or using alternative insurance, will top up 90K. Now, when you have a basket of 150K, what then happens is the hospital negotiates better with the doctor, because they say, okay, so we're going to get 150, we can distribute our costs, so we can comfortably, say, pay the surgeon 50K.
Okay.
All right?
Yeah.
But now, what now happened with the more rural communities or more urban underserved was because of the structure of our population, where they don't, as I said, they don't have cash, they don't have insurance.
Yes.
You cannot take a contract where you have the option of billing them.
Yeah.
So
where are they going to get that 90K?
Yes. So most of us ended up on what was called contract B.
Okay.
Which was supposed to be quote unquote comprehensive.
Okay.
So in that contract, it was very clear that you will not co-charge the client. But then you are given 60K, the same 60K is given to the other hospital that is supposed to co-charge. Now what happened with this is doctors being rational, they gave their labor to where the money is.
Yeah, of course.
Because the energy for doing an appendectomy is the same.
It's the same.
It's just the same. So those kind of issues are the ones that informed having a lobby that speaks to the demographics, the economy, the location, all that.
Yeah. Just to rope in Mr. Experience briefly before we come to the matter at hand, right? And that's quite a good summary, right? What was happening at that point in time? Because certainly, say from not even medical association, from a specialist perspective, right? What is going through doctors' minds, right? Just to give that idea, there's this 150K versus 60K, right? What's going through your mind? You have a patient on the other end, right? But what's happening on your end for you to say, and it's logic, it's rationale, but just to hear from the horse's mouth, as they say, what's happening? Nakuru versus Njoro, what's happening?
Yeah. So health sector is they call it a can of worms. There are very many factors that affect health sector. So I happen to be lucky, having worked in the rural areas in Nairobi. I also ran a private clinic, but I also worked in a place like Isiolo. So Isiolo, even for the public sector, is a whole different ball game. And the first day I went there, and they made me med soup, and I asked how much is the national government giving to Isiolo, because it was so far they were giving like $1 million per quarter to run the hospital. So I came to Nairobi. I asked the finance officer at the Ministry of Health how they expect us to run with $1 million per quarter. But at the end of the day, I discovered National Hospital is not helping us, national government, so to speak. So we went back to Isiolo, and in 5 years, I think we had developed our own way of raising funds, which included ensuring that we collect the little money that the people could pay, enrolling people on NHIF at that time, and ensuring that we increase services and therefore avoid referring. And I think it worked pretty well. So that particular population, there were no cash payers. I mean, they were all... So anytime, for instance, a child came with dehydration and we treated, we waived at that particular time, but we enrolled them for NHIF. So that the next time the family comes, someone can pay for the costs that we are incurring. And that's how the hospitals go. That's rural. So there is a way of doing the arid and semi-arid areas. In the year 2001, when I finished my internship, my first locum was in a rural hospital, somewhere between Mwingi and Kitui. And in that particular hospital, the only doctor who was in that hospital had worked for 4 years. And he had no leave, and he decided he needed to go on leave. So that locum, I went for that locum. So I was the only doctor, and they had... it was in the middle of nowhere, and therefore one of the things we want to bring out here is that you do not choose the hospital that you want to go to. So this is a place which it was a mission hospital, I think, but there was no private in quotes hospital there, and there was no public hospital, but the people there needed care. I used to remember those children who used to come convulsing in the middle of the night with fever, and they needed payment. So that's what we call a typical rural hospital. You get what I mean? And of course they can't afford, you can't see them, but if they had cover, which is what we sort of want to go to, then that's on. Fast forward to 2016 and why Lishenga was able to even do what they were able to do. The Kenya Medical Association has been a board member at NHIF for many years. And the first time they entered there was in 1996, where Kamarogo had to force his way in. They had been gazetted, but the ministry, as usual, did not call them for meetings. They were just used to operate. By now, then one day he went and sat. He went and sat in the board meeting, and the minister threatened him. He refused to go, and from then on, KMA became a board member, so there were several. In 2016, so KMA has always been the voice of the service. It's not voice of the doctor, but the voice of the service. So it is KMA that has proposed that monies in the insurance should cover services. And therefore, they started slowly introducing things like payment for dialysis. You remember, initially NHIF was just bed, you know, I mean, and we were wondering, we as a no, it should be. Then they introduced surgical packages. You remember? And it was now, people were actually now able to actually go to a hospital, get a service, NHIF pays, and they get better. And this improved. And with more and more money being taken to services, then it was possible for even rural hospitals to now start, you know, doing things like that, because someone can sort of reimburse. And doctors would actually come for payment, because part of the NHIF fees was doctors' fees. The issue we had with doctors' fees, and in 2018 we had a retreat with NHIF when they had put some fees that did not include doctors' fees, and in the retreat we put some amounts that, you know, maybe something can come out of it for doctors to be there, and that's how services were able to be expanded, so to speak, in the rural area. So there has been good effect on rural, on the policy input of the associations, and that is the role of the associations. If you look at it on the where they sort of do not like us being there, then it's because we drive the money towards service delivery, you know, as opposed to other things. And therefore,
other things like
currently as we speak, the KMA person in the Social Health Authority has not been appointed. So we have a history of not being appointed, and
you're neglected.
ignored, left out, and sometimes we think it's on purpose.
It's on purpose.
Interesting.
No, I mean, the reason we're taking time to go through this history is because we always want to find out how did we end up at this point in time, right? Because it's very easy if you're an outsider looking in and you see the headlines this past week, and it's very easy to victimize doctors. It's to make them the villains, right? Essentially, why aren't they going to the hospital? People are sick, right? Why is it that they're now asking patients to pay, right? Despite knowing, right? So that's the reason why we've taken through sort of and this is really for you, the listener, where we've taken time for to describe the history. And then we come back to present time, right? And we have a notice, which I think was given maybe a week or two ago. I'm not sure when. But I remember reading a headline that says that rural hospital associations have issued a notice. I could be misquoting. That essentially come Monday, which was this Monday, they will no longer accept NHIF card holders, right? What brings us to that point? And I'm even going to look for the for the article, because when I read that article, I remember seeing, because how it was painted, and you can you understand where they're coming from, right? Because there's a whole list of services that were listed that now patients can't access, right? How do we get there? Before I find the article, what happened by the time you as an association have said we are no longer going to accept NHIF? What has happened?
Okay, so basically we've made a lot of progress.
Yes.
I think Miss Experience here has drawn for you a bit of the journey. So I mean, things are not where they were in 2010, whatever. But any society that stops making progress then dies off. So we must always, and part of what we can do as thought leaders is always push that boundary of progress. Try and get it as far as it can go. So we end up here because of, I think, for lack of a better word, I would say bad manners.
Bad manners.
I want to call it bad manners. Like the same bad manners we are talking about the KMA representative not being, or it's essentially, look, the structures are in place, but we have maybe a deliberate, sometimes it looks deliberate, or sometimes is lack of prioritization of people who are supposed to implement very good policies that have been put there. So in the case of this notice, we have a contract with the NHIF which stipulates that clean claims must be settled within 90 days. Okay. Now, if you go to the private sector, we are dealing with 60 days or less. But we understand that, public sector revenue cycles might be different. So providers have been willing to bend backwards and say, we'll take 90 days in the case of NHIF. But you understand that, let's say, our commercial contracts with our employees, with our vendors
are not 90 days.
They are not
you
90
have
days.
To pay them every month.
Yes. If your nurses have to be paid end month. If you are in a rented facility, it's got to be paid.
You have to.
They are not going to. So
your suppliers.
Yes. So that is the first point. The point of just non-implementation of agreements and not following the law. I will give you a stark example. Let's take the Linda Mama, for instance. One of those things I think we, which is very nice that we tried to do, regardless of, there are things around it. But for me, where I come from, having worked in rural Kenya, I know Linda Mama made a difference.
A big one.
A big difference. Because, you see, if you remember when we had the doctors unrest around nurses and doctors, around 2018, 2019, where I think the nurses went for 5 months, doctors went for 3 months. If we didn't have Linda Mama, Kenya would have, I think maternal healthcare in Kenya would have just collapsed. So I have lived the experience of that making a difference. But we are now looking at the last payments for providers offering Linda Mama having been done in June 2023. So
yet you've been paying salaries.
Yes,
rent,
we are 9
suppliers.
months. We are 9 months down the road. I will give you an example. We have a provider, and this is why I was talking about the bottom of the pyramid. We have a provider who has a facility around Andorra. That facility offers almost exclusively Linda Mama care. Because of the population, the low-income population around that area. So they don't have any other cover. They had a small bill, 5 million shillings over the last 1 year.
It's funny how you say small bill, 5 million.
Yeah, because once you come to health sector mathematics, 5 million shillings for some of our providers is one patient. An ICU admission or something. But this is work they have done for almost a year. But for them, being at a small level 3, this is everything. And for the community, it is the difference between a safe delivery and something going really bad. They have not been paid for 9 months. Their accruals are now 5 million shillings. They got a trickle payment of 50k in January.
Wait, they were only paid 50,000.
They were paid 50k. Now these fellas have nurses, they have pharmacies.
I can imagine.
So how do we end up there? We end up there because people do not follow agreements. You have very good agreements, and that's part of my worry with the new laws that we have done, the social health reforms, because we have very good
we have good policies in Kenya.
And pieces of documents.
We have amongst the best.
Yes, but when the rubber meets the road, we just don't follow. Now, in the case of the current notice, our understanding is that the National Hospital Insurance Fund is defunct by virtue of a Gazette notice sometime in November last year
when SHIF came in.
When SHIF came in, there was the start date, which was essentially also the end date for NHIF. When we look forward, and this is when some of the proposals we put in was that we do not want SHA to carry forward NHIF liability. Because the way we have structured SHA, and we wanted to change even the human resource. People were going to be redeployed or given golden handshake, and the claims management, even the claims management process,
it was going to change because
Section 35 is delegating it. You get so. When we look at it from the provider point of view, we are like, the structure is going to change so much, and our claims are so intricately tied to the structure of NHIF that we think it is not practical for SHA to carry that liability. So in our view was that if you want to give SHA the best chance possible, don't let SHA carry NHIF liability. Sort out that liability, allow SHA to start on a clean slate as much as possible. But now, here's what turns out. I think within NHIF, they also agree with that point. I mean, within the defunct NHIF, the officers who might carry forward, they agree, and a lot of policy people agree that this is the right way. Now we ask them, sort liability. Just sort the liability, because you have a ticking clock towards the transition.
Exactly.
On some date, you have to transition.
Yes.
So the response is... So reconciliation, and I will come to that. But the response is we don't have the money to sort out the liability we have on our books. Then we are like, but where's the money?
Because all this time claims are accruing.
And let me tell you, if you walk down the street here and you ask the common mananchi, they will tell you, me, I pay my card. So there is no way you can tell me that there is no money there. There must be some money there because I pay.
Yes.
Now, so we asked the same basic question, where is the money? So they said, okay, most of our money is held up by government. Most of our money is held up by government and government state agencies. So the National Police Service, for instance, and a bunch of parastatals, and even the Teacher Service Commission owes them money back to before when they moved to their new contracts.
the stories
state agencies or NHIF, and the cabinet secretary is on record, somewhere to the tune of 29-30 billion shillings.
It's held up in state agencies.
Now, you know why we were talking about bad manners. If you fail to pay your NHIF remittance on 9th,
tomorrow I won't get services.
Kwanza your portal shows red.
Exactly.
With a line.
With a line.
With a line.
Exactly.
And that's it. That's the end of story for you. You can't access care.
Yes.
And, and even when you are coming back in, you'll have a 3 months waiting period. And then you will have to pay. Then you pay a fine.
Yeah, exactly.
You get. So this is on the what we would call the common mwananchi.
Yeah.
We enforce it.
Yeah.
To the latter, but state agencies and state officers they simply just ignore
once the money hits their accounts.
Yeah. So here's our point of view. Our point of view is that, in fact, we told this to NHIF. We were in a meeting with them yesterday. The SHA board. We told them we have no differences with you guys because where we are, we understand that your hands are tied, but. For us now, the message is very clear that the government needs to prioritize releasing any funds that it holds that belong to NHIF.
Yes.
The same way they are prioritizing paying anything else, this one cannot wait.
Yes.
And we even went as far as saying, remember, the people who because NHIF is a contributor scheme.
It is.
it's a contributory.
Yeah.
It was contributory. So even these state agencies that we are talking about, somebody was already deducted.
Contributing, exactly.
Somebody was already deducted from their salary. So our point of view is that we are unable, not that we don't want, we are unable to continue providing care without money.
I get that. And I like the example you gave of the Dandora hospital, right? Because essentially for the 9 months, right? I'm assuming, as you said, and I'm doing this really for the listeners as a summary, because if I'm running my hospital, say even have a staff of 10, let's just say 10, I've been paying them for 9 months, right? If it's Linda Manma, I've had some drugs deliveries, you don't deliver and immediately go. You're probably going to sleep that night, right? So there's all that's been consumed, right? All that has been paid for that 9 months, right?
Inputs.
All those inputs have been paid for the 9 months. And it's not that the provider, in this case, has stopped immediately, right? They've been accepting the card. You come in, 9 months has gone by, right? And so by the time we're getting to this point, it's essentially saying it's either we start accepting cash or we'll grind to a halt, not because we even want to.
But it's the reality.
It's the reality. Where else? Probably I've borrowed money, wherever it is, right? No one is going to advance me more funding when there's no clarity over when that's going to be settled, right? So it's not really from an association or even the hospital bad will. It was, even if you didn't issue the notice, at some point there'll be no money. We'll all come and look at each other.
It's a survival imperative.
It is.
It's now a survival imperative because I'm telling you the stories that we have had. A staffer leaves the hospital in the evening, arrives, this is somebody who works for you, arrives at their house, the door is locked.
It has been locked. The landlord is not going to wait for 9 months.
The staffer comes back to the hospital and says, because some hospital rooms are hakuna patients, let me sleep here for the night. This is the kind of situation we are literally facing. And remember the public backlash that we also face coming to our sea, and the drug shelves are empty. There are no drugs. So you're like, we are being ripped off. So essentially the steps are being taken, drastic as they are, to protect healthcare. These steps are to protect healthcare because you look at the alternative. The alternative is zero access. Zero access.
No one is going to.
No one is going to get. But hopefully, our hope is that it doesn't get to the point where the burden on common people is too much. Because remember, every patient who is coming in, digging deeper into their pockets, they are digging deeper into poverty.
Yes.
We are driving them into poverty, and they are getting disillusioned with the state. With their own country. So we really hope that this doesn't persist for too long. The message needs to get out. We hope that the Treasury, for instance, is not stone deaf so that we have to keep these measures for too long.
Yes.
Because we also see ourselves receiving backlash.
Yes, of course.
Because if I abandon you at your hour of need, even when things normalize, you will not forget the bad feeling. So we also fear that eventually Kenyans will say, hata kama mumerudisha the service, that day when I came here and I was really badly off, you guys chased me away. So we are alive to both sides, and our hope is that our partners, on the other hand, they don't push Kenyans to the very limit of what they can bear. That is really what we hope for.
And I think that's a good note to end it at, because then I just want to read the headline. It read, hospitals ask NHIF card holders to pay cash over 29 billion debt round. And when you read that, I had it when you speak to people, it's what you've just said towards the end. People are going to start blaming providers.
Yes.
Hospitals, right? You know me. Probably it's people within your community who you interact with, right? But at the same time, what we're asking is that then they look from the other end, right? It's been 9 months, no payment. I mean, I've worked in an organization where there were arrears going 9 months, 1 year. And I remember that period being a period whereby you're not getting a salary, right? So obviously you've either borrowed, even the savings, you've worked through all your savings, then you start borrowing. You can't even borrow at a certain point. So you think to yourself, I mean, it's an individual matter, then you can resign. But at the same time, by the time you're on board to a new job and whatnot, I mean, such mental anguish. Now you, on the other hand, as a hospital, it's not even an individual choice, your own personal anguish. It's the mother who's coming in every day.
Absolutely.
It is your workers, right? It is not the suppliers. It's you're carrying the burden of that community. And so by the time they're coming to you and say, why aren't you seeing us, asking us for money that we don't have, right? I think people do need to realize, and this is part of why we're having this conversation, it's not one-sided conversation. You're not coming from a bad place. No one here is coming from a bad place. We have pushed 9 months, 1 year, right?
Yeah.
It's yes.
we all want healthcare to work. And I think even when we have, say, differences in how we want it to work, nobody ever says we don't want it to work.
Yeah, absolutely.
So we want healthcare to work, and I think that there is a point where we have to get as a country where we actually honor both the spirit and the letter of anything we write down, whether it is laws, the constitution, or whatever. Because this is where everything goes wrong. I'm just thinking about SHA now. We have a regulation for the benefits and tariffs advisory panel. For instance, I'll just give you something that I think is, for me, already looking like an elephant in the room for no reason. Next week or in a couple of days, you will have Dr. Kigondu and probably myself and other leaders being told, we have a stakeholder engagement for benefits and tariffs. Come and present what you think. Now, there's a fundamental problem, because the law that we have right now says that there must be a panel in place, and we are supposed to even have representation. But there is a benefits and tariffs process happening in the background that, from our point of view, is besides the law. And now we will be called to contribute to that process, essentially legitimizing a process that is now illegitimate. Now, these are the kind of, for me, bad manners things that we do that eventually end up producing a lot of problems. Because in my case, I see that whatever they do now, we are going to be here 9 months, 12 months from here saying that this process was not done in the proper manner. So I think for me, what I would say from our point of view is, when we do laws and people participate, I think where we fall off is implementation and just respect. Respect for rule of law, respect for processes, and it is respect at the highest level of government. Because the common mwananchi has no option. They respect. But where we start falling off is people who have been given responsibility. They start cutting corners, taking shortcuts, and this is why we end up in problems.
Absolutely. I mean, it's the conversation we keep having here with Kigondo about this universal health coverage. It's chaos unfolding, right? And it's not because we do not support. We like the vision, right? We are all behind it, to be honest. But then in terms of implementation, it's not clear. And the common man, what they're hearing is, even if I have to re-register, fine. But come the day we are told that you can now access services, everyone is going to line up, because what people have heard is we're going to be deducted, but it's going to be free. All these other details of whether it's tax, contributory, SHA, tariffs, all these other things.
It's too complex.
It's too complex. All they know is, I will even queue if you ask me to start queuing tomorrow. I'll give you all the details. I'll re-register. Despite you having my details, I re-register. I'll contribute. I'll do all those things. But the day December, if it's December 1st, whatever day it is, July 1st, whatever date it is, I don't even care if it's level 4 level. I do not care. I will show up.
I need to walk in and get my care.
And that's all people care about. So, I mean, it's chaos unfolding. And it's exactly what you say, that fundamentally we have regulations in place, we have best policies, right? Even best intentions.
Yes.
But if we're not following the rule of law, but we're not taking time, because there seems to be a rush somewhere, right? There's a rush that by the end of this year, this must be active, right?
So this is political decision making. I've looked at the timeline, just back to my example, for benefits and tariffs, which, by the way, I have a feeling is going to be the elephant in the room very soon.
Very soon.
Yeah, because we are now going to...
And first, actually tell us, what's benefits and tariffs? Because someone who's listening might be like, benefits and tariffs, what does that mean? So benefits is essentially what... I don't want to say pay for. I mean, it's the suite of services that you are eligible for. Like the Linda Mama,
for instance, you'll be told just what you've been saying, that so if I'm an NHIF or SHA card holder, therefore what am I eligible for? So I am eligible to get outpatient care, I'm eligible to get surgery, and what type of surgery, what type of tests for outpatient care, what type of, if it's cancer, am I getting chemotherapy, radiotherapy? Those are benefits. So it's a suite of services that you are eligible for, or a package that you're eligible for by being a member of the medical scheme. Yes. So that's the benefits package. And then, so there are things which will not be there, and that's part of the dishonesty in our public messaging, is that everything is available, but just by using the word package, you realize there will be something outside the package.
Absolutely.
So there will be things which SHA will not pay for.
Hi.
And
it's
then,
not everything.
No, it can, obviously, and the conversation needs to be more honest, because from what I have heard is that essentially they are going to transfer your current NHIF benefits to the SHA, to be the SHA benefits until further notice. Now, there is no Kenyan I know who is happy with the entire suite of NHIF benefits. We think we can do better. And what has been sold in the public discourse is that SHA is going to cure this issue.
Absolutely, we know.
So there's that benefits package. You're waiting for, just wait for NHIF. Now, you're waiting for that package. And then there's tariffs. Tariffs is now where Kigondo and I will also add our voice, because tariffs has to do with things like, are we now finally going to have in the pricing a doctor's fee, for instance? So if I'm like, the example I started with is even if you tell me an appendectomy is 80K, where is the mathematics for how much I will pay surgeon X?
So that the 80K covers the surgeon's fee, a bed, everything.
So that's a conversation we've really kicked down the road for so many years. Because for me, what I would have preferred to see is a costing that breaks down all these things and says, okay, even I would have even wanted to go as far as the scheme to pay the doctor directly
Yes.
and just remit to the
Hospital, what is due for
belongs to
the
hospital.
actually.
And you know that also now will start touching on the issues of taxes.
Kabisa
my
Kere.
friend because for me as a healthcare facility, I have no business handling the doctor's money.
Correct.
True.
You know, I don't want to do it.
Hey, this is a conversation we need to have.
Yeah,
this,
and you see why I'm trying to show you that is that it goes all the way back to how we even structure tariffs.
This one, we need to have a whole 1 hour conversation on this.
So now the tariff now is how much will be paid by the fund for the service.
Yeah.
The benefit is the service. So this is the conversation that is happening now. The challenge we have had with is it is happening somewhere in a lot of silence.
Kemi has not been invited.
And the few times we have interfaced with it, my sense is that the team also that has been working on this is also in over their shoulders.
I would imagine it's a skeleton team. Because they have to do everything from scratch.
They are buried in all this.
I empathize, to be honest. Because
and that is why we feel that they need all the help they can get.
We're here to help.
They need all the help they can get, and for me, the sooner they would have told...
the sooner they can ask for help.
Yeah, the sooner they would have asked for help, the better. Number one. Two, I think the ministry should have been bold enough to set up this advisory panel. Let them start struggling with this problem now. You know, because you see what they are doing is that by postponing setting up this panel, they are now creating the problem. This problem now is going to be the first agenda item for the panel, which should not have been the case. The panel should have started from a problem solving point of view, that we are a new panel, let us rethink this, let us do this. The timelines for the panel, if you look at the law, I have calculated how much time is needed. It's 9 months if they are working like this. It's 9 months. Back to the question of why the hurry.
Yeah.
You know, I mean, why the hurry? Set up the panel, give them their 9 months, even if it's 1 year. Allow us to interface with them for 12 months, have back and forth, go back, come around, extend our current NHIF contract, even for another 12 months.
Yes.
We don't have an issue.
We don't.
Just say we're putting this on the back burner. Renew every contract for everyone for 9 months. They have for 12 months. There have been people who have been pending contracts. Give them a 1 year contract to be and delaying in NHIF. Let us go and panel beat tariffs for even 1 year. Then we come back and they say, as we have had a national conversation, we are ready.
I agree with you, because then it sounds like we are carrying first the sins of the past, because they said SHA is going to take liabilities of NHIF. So already we are carrying the past with us. That's right. We haven't figured out the details, because the issue is not the policy, it's the details, as you're saying, because then those quickly they will pile on, and then what do we have? A sunken ship again. The road to universal health coverage with the One Health podcast, One Health Lens podcast. We're going to invite Brian again, because now we're going to come with a pen and paper here so that we go into the nitty gritties, because as he says, there is an elephant in the room and we need to address it. Join us next time. Thank you.